whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today we're talking to Dr. Anmol Kapoor. He's a cardiologist, entrepreneur, precision health specialist, and a personal friend of mine. He's a serial founder of multiple companies spanning the clinical healthcare space, as well as digital health and technological innovation. Some of his ventures include Cardi AI, BioRO, Anraton, Dillwalk, and Advanced Cardiology. Today we're talking about precision health. This is a fascinating new part of medicine which takes into account a person's genetic makeup and uses this information as the backbone to diagnose and treat patients with an individualized approach. Dr. Kapoor, thank you so much for taking the time to join us today.
Thank you so much for having me. Really looking forward to see you every time, and it's exciting to be part of your podcast today.
So, what is precision health? How do you actually see this field? Many people out there, myself included, they're very unfamiliar with this facet of medicine just in general. Like, what is precision health in your view?
Well, before we go deep dive into the modern definition of precision medicine, we have to go back to a historical way, like we as a humanity. So go back 100 years ago, 200 years ago, 500 years ago. The health was always a problem, and we were always trying to find a ways to solve the problem. We just didn't know. Many times, we didn't know how to do clinical studies. We didn't have any lab investigations availability, so we had to pick and choose. If you go backward, the stethoscope before the discovery of the stethoscope was itself a tool towards precision medicine. Before that, people difficult for them to listen to someone's heart, and how to differentiate a disease by listening to someone's heart was a step towards cardiology into precision medicine. And the same way, when you look at it, the invention of antibiotics. Before that, people were still having infections. Infections happening now, but people were dying before, and we didn't know how to prolong their life. And ironically, we were using the hot iron to kill those bacteria on the wound. If you watch all those Viking movies, that's what they teach you. They'll show you that if you have a wound, grab this hot sword and then kill those bacteria around it. The infection, suddenly the blood will be clotted, and now you can move on, right? Live your life and we fight again the next war. So, but this is how the medicine and healthcare was. But these trials and hit and trial approaches help us understand that what was working, what wasn't working, and that led us to the new era, the modern medicine, into called evidence-based medicine. So, evidence-based medicine era allowed us to improve health outcomes globally. We start to analyze clinical trials. Yes, it's heavily skewed towards pharmaceutical companies because they're funding it, and they end up funding the clinical guidelines also. So any clinical guidelines getting updated usually are favoring the pharma company because there's more evidence is coming from it. So when there was no evidence, and we just call it no evidence. So example is Lasix. So Lasix is the most commonly used medication in cardiology or family medicine. There is zero evidence that it saves someone's life. So you look at a clinical trial, so people should not be using Lasix, but we still use Lasix all the time. And there are many medications like that. Every day we use them. They don't follow the realm of evidence-based medicine, but in clinical practices we're using it. Why? Because there's a problem. People have it. Why? There's edema, maybe a cosmetic reason, maybe they have heart failure symptoms there. They feel some relief. Yes, long term it doesn't save people's life, but short term it helps them. So they have a problem, dyspnea, they can't breathe, give them Lasix, they feel better. Well, that's a precision health. But yes, in a context of evidence-based medicine cardiology, you'll argue, Dr. Kapoor, there's no evidence about Lasix ever saving someone's life. So, but it is helping save someone's quality of life better. So it is all the mishmash happening in medicine, the challenges we're discovering, we give medication we're giving people. We're realizing that not many people in medicine are responding to aspirin. And there is a one-third population, they are non-responders to aspirin from clinical data, but we still give everyone an aspirin. Many people can't handle statins. We give everyone a high dose statin after MI, and they go home with the aches and pains. Their family doctor look at them and the cardiologist prescribed it. Now they're stuck with it, but patients just can't live their life. We've been giving beta blockers since my cardiology training. That give everyone a beta blocker. This is a ABCD. Everyone gets it: aspirin, beta blockers, statins, and ACE inhibitors, etc. And this is the everyone has to prescribe it. Now look at today in 2024, beta blockers are no. Unless there is an LV dysfunction, no one should be on beta blockers. So it doesn't matter they have MI, don't have an MI. So even after MI, after discharge of hospital, there's no need for beta blockers anymore. And you can imagine the evidence-based medicine started. Who invented beta blockers? Pharma companies. They picked up a clinical trials and the studies they did it at that time, and they helped meet the guidelines. We start following the guidelines, prescribing beta blockers to everyone. Men end up developing erectile dysfunction. Depression got worse. Many issues happened, but we kept giving them, kept dumping them because the guidelines said it. And a cardiologist said it, we have to follow that because evidence-based medicine. So people hated it, but it's evidence-based medicine. So there was some data supporting it is going to help make them people live longer. But now when you look at the data, oh, we are sorry, we should not have been giving people beta blockers. Oh, we are sorry, we were giving people stents, everyone who's coming into my office all the time. So the cardiology practice was, you see a blockage, put a stent. See a blockage, bypass if you can stent it. But now we say that, oh, sorry, we don't want to do that now because it doesn't save someone's life. They are like symptom relief. If you're having an angina is not getting better with medicine, and let's try a stent or bypass. But we know that stent or bypass doesn't avoid MI, doesn't prolong someone's life in most cases. Only in acute situations when someone's having ACS, acute MI, then stents can help save someone's life. But in a stable CAD patient, there's no benefit. But we've been doing for 20, 25, 30 years. So you can imagine how many humans we implanted these unnecessary interventions without knowing, but they were quote unquote a part of evidence-based medicine. But in a way, there are all these questions coming out of it, and then people start saying, how can we provide a better care to humans, to all of us? How do I want to get a health care delivered to me by my colleagues? Obviously, I want them to know who I am as an individual. So I want them to know what is my genetic makeup is, what my gut microbiome could be, and how those drugs interact in my stomach with my liver, how I metabolize them, and this way the normogram that is published by a pharmaceutical company or pharmacy give it to you or the patient, at least I know which actual side effect matters to me, which unnecessary side effect I don't want to have it. If the drug may not be right for them, I'm a Chinese person, so perhaps 80 milligrams of Lipitor is going to cause me the problem. So rather, I should have a lower dose. Maybe better PCK9 inhibitor is a better approach. If I'm, despite being on the target, I'm still having an MI. So it means there's a lipo-A mutation, there's a ApoB mutation out there. So all of those question marks were in cardiology all the time, but we were not deploying them in clinical practices. So now we have the tools, we have the knowledge, we should be, all of us should be practicing precision health. We all of us should be doing to a favor to our patients, to also to ourselves. Because the patient we are treating with the traditional system, guidelines-based therapy. Guidelines management is a bare minimum expectation, but somehow it became the maximum in healthcare system. So what the guidelines, the idea was when came into the existence, because practices were all over the place. So we said, okay, let's bring them together, make a minimum guideline. If you have this clinical problem, at least follow this minimum pathway. But we made it maximum pathway. Our exams are based on guidelines based now, and if you do this ABCD, done. You have to do anything more. We as a doctor, we stop thinking. We just go open the guideline, find out, okay, I have to, this patient scenario is this, okay, I'll do A, I'll do B. After that, if B is failed, A is failed, I will do C and D. But now we have an era of ChatGPT. ChatGPT can read guidelines better than a doctor. There's no need for a doctor to follow this A, B, C, D. ChatGPT can read up to date. So why does a doctor needs to be even play a role in that? So fast forward a few years, there's no need for a family doctor in that regard because everyone we train, we go to up to date. We learn from up to date. We find a pharmacopoeia. ChatGPT can read all of those things. So all the clinical trials are getting fed in many AI-based databases. So where the things all come into play in medicine is precision health. So what matters is Someone needs an antibiotic. What kind of antibiotic is good for that person? Do you even need an antibiotic? If it's needed, what kind is good for them? If you know the sensitivity when you're prescribing, that person health. When you are prescribing without knowing the sensitivities and the resistance of the person, that is called hit and trial approach, evidence-based medicine. So that's the differences. Knowing prescribing, unknowing prescribing is evidence-based medicine and a person health.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today.
So the evidence-based medicine, the studies, the guidelines, that gives us approximations for broad kind of groups of patients, buckets of people. And then precision health really comes in and distills down the exceptions and, the people that don't fit those parts. So you made a good example. My next question was going to be, is it all genetics based? And then if not, why not just call it part of medical genetics? Why does it get the fancy name of precision health? But that is a great example of the antibiotic sensitivities falling under that umbrella then.
It is essentially anything we want to do in medicine is a precision health. We don't have to be. All these are data sets. So we look at X-ray. X-ray, the data set of a pneumonia. It is a possible pneumonia, but X-ray itself having a lesion doesn't define pneumonia. Pneumonia is a clinical diagnosis, having a fever, a cough, productive cough, and looks like it with some lesion on chest X-ray. But chest X-ray alone itself is not a pneumonia. So we don't treat X-rays. And we treat the symptoms. So that's precision health in that context. So it doesn't involve genetic testing in that regard, but genetic testing helps us in many different ways. So it helps us understand the predispositions in the data set. So could this person, the lesion we are seeing on X-ray, could that be cancerous? We don't know that. So sometimes we give an antibiotic, the lesions are not getting better on X-ray. So what it could be? We can biopsy it. It's very difficult to access that area. So what do we do? To keep doing the CT scans all the time and monitoring them? Or perhaps what we can do is we can do a whole genome analysis, understand what is happening in the predisposition of that person. We can do cell-free DNA testing to see if any cancer cells are floating in the blood. So we can see the active cancer is actually happening there. If there's no cancer cells actually actively in the blood, there's no predispositions, probably it's not a cancer. So it may be something else. Could that be a fungus? Oh yes, we can. We can do laryngeal swabs. We can do oral microbiome analysis to understand. We can get the whole investigations done from a laryngoscope perspective. What are the areas we can try? Get some samples. Do a microbiome analysis. What the medicine does it. So when we're doing these samples, we are extracting. We are culturing it. So by using culture technology, now you use a next-gen sequencing technology. By doing this, you can now analyze all the bacteria, all the fungi, everything in the sample. Because culture will take you 7 days, maybe 14 days in some instances. You have no idea what the sensitivity or specificity could be. So if you can sequence on the same day, when you're getting all this extraction you have completed from a respiratory perspective, and you can sequence, you understand on the same day what actually is happening there. So now you can get to the precise problem in that lesion on the X-ray identified at that time. So precision health doesn't involve genetics. It can help answer, but same time you can use the next-gen sequencing from the microbiomic perspective, and every sample should be sequenced. The era of growing and culturing is ending. The era of sequencing is starting.
That does sound kind of barbaric. Like, okay, we want to treat you, but we're actually going to wait until we have 8 billion organisms grow in this petri dish first, versus, yeah, let's just sequence it and we have everything we need right now today.
Pretty much. And fast forward 10 years, imagine how our juniors will laugh at us. They'll say, these doctors used to be practiced hit and trial approach. They have no clue. They were eating antibiotics like candies. And they don't know. They have no idea. They were guessing the game. Oh, X-ray, maybe MRI, maybe CT. No one was using these advanced technologies, and they were killing people. The way we laugh at people, how the fractures were happening before X-ray was invented, but after X-ray got invented, we start managing people with the fracture differently. We start laughing at them. How are you practicing medicine without X-rays? So same way how we are shifting healthcare towards precision health, everyone should be practicing precision health. If you're not practicing precision health, you're not practicing medicine. You're just doing quackery with the gut feeling, with the gut microbiome, with the gut feeling. So using gut-brain axis because your dopamine is 80% made in the stomach and acting in the brain, you're feeling the gut feeling, which is scientific evidence behind that now. So using the gut feeling and your experience, maybe something you have learned from your friend, let me try on this patient. So that's we call evidence-based medicine, but not a medicine. We're doing a hit and trial approach on a real human. If you know the precision health, we don't have to do a clinical trial like that every day.
And what are some of the, I don't know, perhaps the quickest growing or, the biggest leaps or advancements in technology that we now have access to today, where there is no barrier, there's no like approval or government hurdles in the way that like your average primary care provider has access to right now? What are those things that you're getting the most excited about of like, okay, we got to transition from quackery to healthcare properly?
Well, I'll give an example from a cardiology. I'll go back to the basis what they can easily access is ApoB and lipo-A levels. So in Alberta, we can get a ApoB level assessment. Many family doctors are still doing LDL game. I don't measure LDL, I don't measure HDL. They still do calculate the ratios. And they decide, okay, based on the ratio, I'm going to adjust the medication up or down. And many times they prescribe a middle dose statin and they lower it down because they're looking at the ratios. And it's a wrong way of medicine practicing. They have the tools, doesn't cost any money. They can check something called ApoB level. Don't check LDL level every 3 months. Check ApoB levels. If they are low, you are going to help make a person live longer. Check lipo-A levels, see if they have a mutation there. It is covered by Alberta Health, doesn't cost us any money. If there's a mutation of lipo-A, statin may not be a good approach. Perhaps add on PCSK9 inhibitors. So there are tools out there. We just get stuck to the same guidelines because the lipid guideline says I have to follow the ratio. So, but we forget that there are more tools outside which are covered by the government. Another example is 24 blood pressure monitor. So hypertension is the first thing we measure in any clinic. Someone comes to clinic, what we do? Hi, Mr. So-and-so, please have a seat. Let me check your blood pressure. Let me get to know you, what you have the symptoms. When we check the blood pressure, all the machines you have in the doctor offices, including my clinic, they are not clinically validated. We buy from Omron or a bunch of those brands out there. None of them are clinically validated machines. And what we do is we make a decision based on that. We say, look, well, my data in my clinic may not be accurate because doctor office is a white coat syndrome. Why don't you try the same machine in your home? Yes, it'll be a little bit lower, but the machine is still not accurate. Still not clinically validated that I bought from Costco, from Walmart for $50. So what we're doing is we're relying on that data set, randomly numbers coming in, and then what we do is, okay, perhaps maybe the home number is high, maybe the pharmacy number is high. Let's give him the hypertension medication. Let's see what he does it. The patient hates it. There's less compliance. You know that from clinical practices. 60% people only take hypertension medications after prescribed after 3 months. Not everyone is taking every day. As we assume we are doing a good job, we are not. Patients stop taking because they feel dizzy. They have a side effect from that. So we have not even confirmed the diagnosis the right way. Even the machine is not the right one we are using right now. How we should be doing it? We should be doing a 24-hour blood pressure monitoring. Alberta is the only province in the whole Canada where they cover the test. You don't have to pay anything. You go to Toronto, people have to pay $80. You go to Vancouver, people have to pay $80. So that costs them money, yes, $80. So let's say the socialist system, Alberta is covering everything, but we are not using it. So let's first get the diagnosis of blood pressure defined. Let's see someone has a high blood pressure first of all, and then you prescribe the medication. And if you prescribe the medication, how are they responding to the medication? Maybe they need to be added more medication. Maybe they have early morning high blood pressure. Maybe the medication is wearing off in 24 hours, in 20 hours. By the time they're taking the next dose, blood pressure is spiking up. They're getting a stroke at that time. How do you know if you don't check the blood pressure for 24 hours? We have the tool, we have the machines. Doesn't cost anything to practice precision health much. You don't have to be super smart for this. Just order 25 blood pressure monitor test every day, every time you adjust the medication, every time someone's coming with dizziness episodes, every senior you're going to prescribe a medication, just do ABPM first before you do any other change.
So it's definitely existing, but perhaps underutilized right now. Like, do you foresee there being a change to our medical education system? Now we've got kind of this sexy headline for it, right? Of doing better medicine under the umbrella of precision health. Like, does this need to be more of a like prominent part of the education and the curriculum of how to start really making sure that not only are you aware of these different things and tests and treatments, but like what's covered, what's funded, how to access them. How do we start actually changing the medical culture to be more in line with that better, more accurate care?
I think all of us, amazing question, but I think all of us has to work together. We are the part of the same team. You're a family doctor, I'm a cardiologist, someone's a surgeon, and what our colleges train us and what our doctors become used to, that you work in your own silo. And you work only as a cardiologist, I'm the consultant. So me as a cardiologist, I can give the advice. So if I'm going to make an intervention, if I see a patient diabetes medication needs to be adjusted, but most doctors will stay away from that. Let GP handle that. If I see that patient haven't done a bone density exam and patient should be done a bone density, we have more fractures happening in Alberta than other part of the Canada. We don't do bone density scans at all. Look at North Alberta versus South Alberta. South Alberta is really bad. More fractures spontaneous happening than Northern Alberta. So we don't even use the existing tools we have. And why? Because the specialists, the colleges teach us, you stay in your own lane. Other doctor will stay in their own lane. You are the consultant, you advise, you don't intervene. Other person says, look, I'm the GP, let me intervene, but GP is busy, they're overburdened. There's so much work for them to do, they have no time to read all these letters and follow those patients. The system is wrong. I think all of us, we should be acting on whenever you see the patient. Whatever the gap in that patient healthcare is, address it because that may be the only time patient will see that healthcare provider. They may not even see the doctor for 6 months or 1 year. So in that 1 year, 6 months, they already have the disease progressing further. So by then, if you see something, fix it. We have to change this whole culture of specialization and a GP and a consultant, advisor versus someone taking an action. I think all of us should be consultant. All of us should be taking actions if we truly want to make a change. And then we can all these tools that are available will be using actively. Otherwise, hypertension management is internal medicine's problem. Cardiology problem. Rheumatology, that send them to them. So who's managing anything? No one's managing any of those patients. They go to appointment to appointment to appointment, but nothing gets managed properly.
Yeah, they wind up floating around between services. Everybody's scared to step on each other's toes, offend somebody, undo something. 100%.
I don't know why. I always have people offend me every day. Don't hesitate. I will never mind because you're acting in the best interest of the patient. I may have missed things. I may not have seen it. I may have been very busy on that day. I may not have looked at the lab properly on that day. Mistakes can happen. We all are humans. And no one is perfect. But if you see it, you act on it. If I see it, I'll act on it. But we should not take it personal.
'Tis better to have investigated and got a slap on the wrist than to have never investigated at all.
Exactly. So the patient, because if we don't investigate anything, we don't follow with anything properly, who's going to pay the price? Our own patient, our own families.
Yeah, so many delays.
Yeah. So think of this way. So yes, to me today, I see a patient, but patient is a father of someone, mother of someone, sister of someone, brother of someone. If I'm delivering them suboptimal care, when my brothers, sisters, mothers, fathers are going to the same system, they're getting the same suboptimal care.
And so you yourself are clearly very passionate about the field of precision health, precision medicine. Like, you literally just got back from an international business trip for one of your several businesses in the precision health space. Where did that passion first ignite from? How did you even find an interest in this field to begin with?
we all are scientists. The question was why my people are not getting better, why my patients are still having MIs despite they are meeting the targets. So all the guidelines based therapy, why is still coming back with the stent failure, thrombosis, why there's a cardiomyopathy, why only certain people with COVID vaccine got myocarditis, not everyone else got it, why certain people are getting these diseases, why not others, so why certain people get side effect, why not others. So all these questions were going in my mind, and the healthcare system was not ready to provide me answers. It is a bureaucratic system, we all know. I don't want to keep going on the topic. You'll have a whole podcast on that. It'll be still not enough time. So the answers were not there. The system didn't want to give me any answers. So I started seeking answer myself. So that it could be my upbringing, where I brought up in India, so that you have to seek an answer within yourself. That's been taught in our culture. So I thought, okay, let me see what answers I can find for my patient, for my own self discovery. So that led me towards the journey of precision medicine, precision health. And when you have a question as a scientist, when you ask, you start looking for an answer. One answer led to other answers led to some other discoveries. So that journey has been so enlightening, so happy, and I love it. I'm passionate about it. I hate my everyday cardiology practice. It's boring, it's suboptimal, it's bad for the patients. I'm doing a bad job, but I can do a good job unless I have the precision health tools. Many people can't afford, unfortunately. People who can afford, I give them the best health care. People who can't afford, I'm giving them the bad health care, knowingly what else I can do.
I have a feeling you're doing a better job and better service for your patients than you give yourself credit for. But I do appreciate, the desire for more and advancing the field.
We should be all like, I'm maybe a self-critical, thank you so much, but all of us should be, hey, we should be thinking what's best for my patients. We all think that way, but we just sometimes get busy in our everyday practices and lives, because we work hard to become a doctor. It's not easy to become a doctor. There's so much social, moral, family responsibilities on us. Our one mistake can be glorified and up on the media. Could be a small mistake, but the biggest things we do, the lives we save, we are the heroes. No one likes them. Always something happening. Heroes are always the firefighters or the policeman. Doctor's never a hero. So, and nothing against those, though. They do also work hard. All of us responders work hard, but somehow doctors are never considered heroes. We know that. We work every day. We save so many lives. The impact that we have on the families and the communities, the countries is huge. So that led me to get more discoveries in this area. So I traveled to Taiwan. I just came back a couple of days ago. It was a BioAsia Congress, and they invited me to be part of that. Canadian consulate and ambassador. So they had a special ceremony there. Last year, they invited me to introduce what I'm doing as the technologies we're working on. And this year, they wanted us to sign an MOU with all the computing companies there to showcase technologies that can be deployed at a larger, wider scale. So this barrier that exists right now in healthcare globally could be broken down and becomes more affordable and more accessible. So I'm excited. I'm passionate about it for next 2 to 10 years period. I think everyone will be practicing precision health. So I'm just get 2 to 10 years the period I'm giving it, because some countries are more advanced than others. But in about 10 years spectrum, I think most will get there.
And so you are involved in a few different facets of precision health through your clinics here. So you guys, you started with BioRO, the gut health one. Is that correct? That was number one. And then has since moved into the skincare realm. It has moved into the like sports and athletics realm. Is it, where else do you actually have spread going on actively?
Well, all these are problems are getting solved through precision health. The BioGut Clinic, which is called biogutclinic.com, anyone can access that. It's a private funded program, and it's a 3 month rehab program for the stomach. The idea we stole it from cardiology rehab program. So it's rehabilitating the
Yeah.
stomach. So how do we do it? First, we diagnose the problem. What is the problem? The problem is IBS. Every third woman has IBS. Every fifth human has IBS in Canada, and IBS is like a migraine of the neurology, and it is a palpitation of the cardiology. So family doctors and everyone dealing with it They don't know how to deal with it, how to manage the problem.
Very frustrating for everybody.
Frustrating for many people as the quality of life deteriorates. Patients are frustrated. They're trying these PPIs and a bunch of treatment. They never work. They make it worse. So how do we practice precision health into IBS? So we took a gut microbiome approach. Do a gut microbiome is a shotgun approach, means everything in that sample, and do the proper analysis, and then have a intervention based on a dietitian, psychologist, and a kinesiologist, because IBS has a multiple facets. It is a mental health facet, exercise facet, nutrition facet into that. Let's bring them together. In BioGut Clinic, our staff does not even sell anything. We don't even give you a meal plan. We don't even we don't sell you anything. There's no multivitamin packages sold to you or something dumped on you or upsell some subscription for you. Nothing is
You
done like
should
that.
maybe consider having a monthly box of magic ointments that arrives every month to accompany the data.
This is a commitment. You'll have to commit that you're going to follow 3 month regimen. These professionals will prescribe for you depending on your symptoms. And you have to interact on everyday basis. They have various touch points along the way in 3 months. Then they do gut microbiome testing again end of the 3 months to see if this virus is better, if your symptoms are better, if you have learned how to manage your symptoms properly. So if you can do that, you feel more empowered. You can live your life more comfortably. We have people as far as from Ukraine accessing services now. So we have people who have these IBS issues for 20 years, 25 years. When they're graduating from 3 month program, they literally are crying that no one paid attention to them. We're just working with them, with their environment, not trying to change it, just try to improve it what they have using precision health approaches. So now we moving into the Biosport side. So Biosport is a separate company, and we are spinning it off. We have never raised any capital for any of my ventures so far. It's the first company we're going to raise a capital for. If someone wants to come in, they will be have an opportunity in it. So essentially tackling the over exhaustion and overtraining injuries in the sports area. Last year, about 5 million people got injured in America alone, and not knowing when they have to stop. They overburden themselves and they shorten their lifespan while playing sports. We know that 1 in 40,000, 1 in 50,000 occurrence of sudden cardiac death when playing sports. So we know that there is genetic risk that are linked to sudden cardiac death. HOCM, hypertrophic cardiomyopathy, long QT, Brugada, you name it, the many syndromes in that area. We cannot pick up a ECG alone. So why don't we bring in precision health into the sports realm? So what we learned was we stumbled upon this issue from one of speed skater from Canada in Calgary. He's preparing for Olympics. With Winter Olympics, he wants to win, and there's a difference of 0.05 second difference between a gold medal or any medal of a no medal. And he wants to see genetically or microbiomically in his stomach how good he is, what he can improve to find that extra edge. And we did work with him. We learned that by the knowledge he learned, he ended up winning a silver medal at the World Championship. So we realized there's something out there. So yes, we know that there are elite athletes out there, Messi's, Ronaldo's, Zidane's, and you name it. So they're elite athletes. So they have a different makeup of genome versus other people. Some are very exceptional on the field, some are not exceptional on the field. Some get more injured all the time when playing hockey. So there's genetic makeup that matters. So we realized that based on published literature, we came up with a polygenic score called a biofit score. So by this score, we identify you from the whole genome analysis. First, we rule out the risk of sudden death, check heart safe. Second, what's your biofit score, depending on your genomic profile. And then it puts you against elite athletes. Are you good in endurance? Are you good in speed? Are you good in power? Are you good in muscle building? In my case, I'm not good in muscle building. If I'm going to want to be the Arnold Schwarzenegger, there's no chance I'll be ever become. Even if a muscle mass I'll be able to make, I lose it very fast. I'll have to really have to do more exercise to keep maintain whatever I have. But if I don't know it, I'll be keep pushing myself, getting injuries. So that's what they cause more problems. So by knowing, then I can channel my interest in the direction where I'm strong at it. Endurance, I'm good at it. Speed, I'm good at it. Perhaps my hobbies could go in that direction. My kids could be moved in that way. So using their strength and making them more successful than going the rabbit hole of making NHL hockey champions. They may never become. Only two kids from Calgary go to NHL on an average. But many dads want their son to see in the NHL playing, but they are not made up for genetic makeup. We can help them understand early on, and they can perhaps plan better sports for their kids. And we can then reduce injuries, extend the lifespan of a sports person, and or as a hobby person, and improve our overall wellness and longevity. So this company is called the biosport.com. We are going to launch it soon, later this year, and allows us to first time use the power of microbiomics, whole genome sequencing, and personalized AI-based access programs on everyday basis.
And so let's say like somebody like myself, not the Olympic contender, just viciously mediocre at all things athletic. What kind of like actionable insights would I actually see going through the genetics testing and so you guys do the the gut, the gut biome and the person's DNA.
It's the same thing, I guess.
What would I actually learn, or how would that be relayed to me, and what kind of things would I then do differently, assuming I didn't already have like a one-track mind, and whether or not that's like a fit or not fit?
Well, main thing is we go to gym, like you and me. We are weekend warriors. We want to make sure everything is doing properly and safely. So we rule out the risk for heart disease for you, and there is a polygenic score for that. So we rule out any chances you may have any of those risks. We can help you along the way. That's number one. As we get older, the risk for heart disease, certain death is higher. So we can rule that out. Second thing is how you can be improve you better. You want to go to maybe perhaps play squash, maybe badminton. Perhaps you know your powers. You can play sports accordingly as a hobby. It'll help you how to train yourself. You're training already, but now with the knowledge you're training, your training level will be better. So not just someone coach, you have a personal coach maybe guiding you along the way in a Calgary Winter Club or some other places. But now you have a genomic information which you can use to get much better output versus what you're using right now. From a gut microbiome perspective, there are certain bacteria, how they metabolize the type of food you eat, and how the ratios are. So if the ratios are not the right ones, your energy store is not getting created the right way. You're not consuming the right way. You're not metabolizing lactic acid the right way. So all of those little nuances you'll learn along the way. You'll improve your hydration properly. You'll be able to improve your diet. Perhaps don't take keto diet. Maybe perhaps other diet is better for you. So we'll be able to help improve it so you feel more energetic, less fatigue, less tired after exercise. Many people feel tired after exercise regularly as a hobby base even. You go to hiking to Banff, come back, you feel tired for 2 days. But let's avoid that. Let's prevent that. So this way you can stay active for a longer period and end up living longer life. So biosport is, yes, it can help the elite athletes, but it can help everyone.
And then are you doing things differently in an attempt to change like the ratios of the microbiome, or are you like playing to your strengths and then it is what it is and it's set in stone unless you take too much antibiotics and get C. diff?
Nothing is set in stone. That's the beauty of precision health is people believe you're born with DNA done. I'm destined for death. I'm done. I can't change anything. You can change a lot of things. Everything you can change. Microbiome ratios can be changed. We have shown that in BioGut Clinic. Dysbiosis is better of the patient with interventions we have done successfully. The symptoms are better. They have better quality of life. They feel more energetic. They have less depression, less anxiety, better management of the panic attacks. We have tackled all of those things with just simple interventions. So we can do the same thing in the sports side.
And then what about the skin aspect? How do you actually play into that?
Skin, beautiful area. In fact, the skin ages and the skin microbiome changes as we all age. For example, seniors, as we have seen in practices, the wound healing is slower. Diabetics' wound healing is slower. The older you get, the wound healing becomes very, very slow. We always think it may be the circulation problem. We are forgetting it's a microbiome problem. that is living on the skin, not letting heal properly, because we age very fast on the skin level. And we can slow that process down very easily. In fact, you can predict someone's biological age based on skin microbiome more accurately than the gut microbiome. And you can get it within the period of 4 years. So if someone is 30 year, you can get up to 26 to 34 year age group. So you can get a much more accurate skin microbiome than the gut microbiome side. So skin microbiome can tell us why we have eczema, why we have acne, why we have rosacea, why we're developing certain rashes. So skin microbiome is very helpful in that area. For example, acne is a blessing. So people who truly want to live longer, want to look younger, longer, they should bless they have acne when they are born, when they're in the teenage years. If they never had an acne, their skin will age faster
Really
on their face.
interesting.
Yes. So because acne bacteria that grows that causes acne, there's a microbiome linked with those things. It is certain people have a oil production, certain genomic variations they have it. So that has a positive outcome in the long term. So people who have acne in the past, in the teenage years, they look younger longer than their friends who never had acne.
I look forward to looking long and everlastingly beautiful based on my past history of many, many pimples when I was younger.
There you go. It was a blessing. You hated at that time. You were looking for girlfriends, and they were all perhaps you were thinking about it. Man, my friends have more girlfriends than me, or whatever. So now you can say, look, I look younger than them.
I will have the last
So
laugh.
exactly. So you see, his acne was a blessing. You didn't know that. This is how the skin microbiome plays a huge role. We can what we do is in eczema, we look at the reaction outside, it's inflammation. What actually is causing? We have no idea. What is the treatment? Give a steroid. So that's the only way it is stand. You go to dermatologist, they give you the same thing. Steroid low dose, steroid middle dose, steroid higher dose. In the end, it's steroid as a treatment. So, but without understanding what is happening to the microbiome. So we are going to deploy the skin microbiome approaches. So in a company, we have patented a new method that the way you grab a sample and you sequence a sample because not every sample grabbing is good. Many people do skin microbiome testing, but the report comes back negative because the yield, when you grab a sample, the yield is not as much versus the method we have discovered is a better yield when you sequence that. So that allows us to get into the know your age, skin age side, know the right treatment, right cosmetics, because we know cosmetics does kill the microbiome and it does cause problems. Have the right sunscreen, that protect you against the UV damage, because that also changes the microbiome. So all fascinating things in dermatology will be changed in the next 5 years. Knowing genomics, knowing microbiomics of the skin, we can really alleviate many issues and we can make people live younger longer.
How do these types of businesses come to be? Like, I'm just trying to envision the process from, we have research going on at academic institutions, and papers are continually getting published in terms of like, okay, we've seen a link between specific genes and specific like, clinical conditions or outcomes. And then there isn't necessarily like a business actionable insight based on these individual things. It's not like the pharmaceutical company is necessarily like got a drug ready to go based on this one condition, and it's not, I guess, widespread enough to be able to influence the guidelines in terms of that traditional evidence-based medicine approach. So then these papers kind of just contribute to this body of knowledge. And then when it comes to the actual application layer of how do you take that wealth of information and translate it into a patient, like walk me through the process of just how you actually take all of that and put it together into a flow or a process.
Thank you for asking. The most research when we do most scientific research dies in the research on the research table. People write the paper. The most discoveries no one is reading unless we go to a conference and some colleagues mention something because we all busy. We don't have time to read every topics there. So my approach is to look at the clinical side, how we practice in businesses, how we open the businesses. medical aesthetic is a huge business, and people using Botox, yes, discovered for some other reason, but there was a benefit on the skin side. They made more money on the skin side than the reason they discovered the Botox for. So yes, there is a problem, the market out there, but the market is needed looking for something new. So market wants to look more younger forever and longer time periods. So what other ways we can make that happen? Yes, you have done the Botoxes, you have done the fillers, you can do all these things along the way, but they'll repeat. They're not improving. And Botox, most businesses lose money. So Botox clinics are losing money every day. It's a net loser. Anyone wants to do Botox clinic, tell them not to do it. They will lose 100% money. Okay, is a net loser, I'm telling you. So, but now where you can make money in cosmetic business, you can make cosmetic business in the treatment, new technologies, new things you can bring on board. You can do slimming and trimming. That business is suffering now after it went Ozempic. Before that, cool sculpting was stock was so high. People buying all these machines, fat burnings, using various machines. After Ozempic, stock went down because people are not using those machines as much. So since they're not coming to cosmetic businesses, machines sitting idle now. So what else more you can do? So you can add on skin microbiome and precision health based these solutions. You can advise people the right cosmetic they can buy. You can provide them personalized care in that regard. So they come back to you again and again. So that's knowledge they're looking for. They will not get this knowledge from Sephora when they go to the market mall, but they'll get from your clinic. So those tools will make that available for you. You can contact our office. We can guide you, empower you. You don't have to use it. You can use someone else. But there are other ways you can add this value to your business.
So it comes down to, I guess, the private system is funding this for now. There just hasn't been like a fee code for governments to fund you to go see your family doctor and do these analyses yet. And then individual clinics popping up, distilling that information. I mean, when you say like bio gut clinic or biosport, would you call it a clinic? Like it is truly like a clinic with like a clinician interpreting test results, or is it more of like a testing business, I guess? How do you actually think of it internally?
I think the COVID has changed that whole realm of that. So many people now practice telemedicine, and that is a clinic using Zoom, a clinic using some other virtual health platform. And but it's a clinic. It's not the same brick and mortar way. So and the clinic is changing using AI. So Chat GPT based tools are available right now. You can connect your Fitbit, Apple Watches. They can monitor, provide you guidance. You need a doctor, a human doctor in that regard. But they are virtual clinics now. So the definition of the clinic is changing. So it's not the same way you have to go to small address or big address and go to see a doctor there, sit down, book an appointment. I think that is going to change a lot in the future. So yes, we call a biocut clinic because there's a human intervention. In a biosport, we are not calling a clinic as a technology where AI and genomics working in real time for you on demand. Yes, you can have a human intervention available for you. You can private pay, get an access, or covered by the government. The government usually are slow. I was told by my gastroenterology colleagues in Fortis Hospital that after FDA approved endoscopic ultrasound machine, it took them 15 years to buy their first machine after approved by Health and FDA. So that's slow the system is. So gut microbiome sequencing, it should be done on every patient and present to the GI department. They don't cover it. Right, because they don't have the money or the tools. So the software analysis systems that cost a lot of money. The reports come back a little late. So where we saw the opportunity to help improve those barriers, those bottlenecks, so of the future doctors then can access these services on demand, become so cheap that it's cheaper than ordering a blood culture. You can do a sequence. So this way, there's an incentive for healthcare systems to provide the billing code because they have the money, they have a fixed budget. I have to give credit to them, and they're trying to see what to delete, what to add. Because they have to delete something, is there something cheaper and better option? So we as a doctors have to present those.
Yeah, slowly that changes over time. So you've got the test, but then it's also a lot of the interpretation of, because it's not just like unidimensional, like you get a yes, no answer is my, red blood cell count out of the normal range. There's a lot more to it. And then the application of what to do next. How do you actually translate that into real world patient advice of what to change and how to do things differently.
It is. Think of this as another tool for you. So you have a patient with a name a scenario. Why don't you guess? Say a scenario. I can help you understand how you can practice in that.
In terms of like a patient case, you mean?
A patient case, yeah.
Does it have to be GI or literally anything?
Any case, just pick up any
Uh,
case.
treatment, yeah, treatment resistant depression. Patient's been sad since they were 7 years old. Nothing works. They haven't tried ECT yet, but literally everything else. How do we then leverage the magic of precision health and genetics?
Thank you. So, how I would practice is I will look at it. Why, first of all, depression there is a genetic predisposition for depression. I want to see what kind of genes they may have that putting them at risk for actual depression, and the type of drugs they're getting a pharmacogenomic analysis to see how they're metabolizing the drugs. So sometimes people are resistant to these drugs because they're hypermetabolizing or hypometabolizing, or may not be getting the right quantities. So I will be doing a WGS analysis, getting a pharmacogenomic analysis for that patient. Then I also look at the gut microbiome because the depression patient, the gut microbiome has a significant dysbiosis. They have a less bacteria that produce serotonin and the positive messaging and the hormones connections. So they have a bed of those bacteria growing. So I would then adjust their diet from that perspective. I would recommend more exercise every day and have a gut microbiome help me along the way. In the pharmacogenomic side, I'll use it to optimize their treatment strategy because the drugs they're using probably is not the right drugs they're using it. We think they're resistant because we assumed we tried everything and all the doses we have tried. But a pharmacogenomics gives me a different angle and perspective. When I go back to this patient, I'll be able to provide a better care using these tools, and perhaps he doesn't have to go to extra extreme treatment strategies. Maybe we can stop it there. Perhaps move towards a better, happier mindset.
How extensive, like today, right now, is that data set? Let's say for the pharmacogenetic side of things. Like, is it based on individual drugs or more like the metabolism pathway? And so even if there is a brand new drug, if we kind of know about it, we'd have answers already if the patient did sequencing.
All the databases are there. They existed. The UK did a beautiful project where they asked GPs last year, I believe last year, before they prescribe antidepressant or common medication, they asked them to consider doing pharmacogenomic tests. And based on that, they adjust their medications. I'm looking for the outcomes. I have a feeling that changed the practice. There'll be landmark study they're going to publish when they're going to publish it. And there's enough data out there. It is there, is openly well published, open libraries of the data, which genes, how we metabolize it, which medications, new, old, all of them are there. It just what happened is the guidelines are funded by the pharma company. Pharma company has to sell the drug. So we don't want to look at their databases. We only look at the guideline, which is funded by the same company. So we have to open our mindset. Genomics gives us that power, that confidence. Look, I'm prescribing the right way because it's well published, well researched in a literature by my peers. Yes, it's not pharma funded, but well published.
And if somebody has already done genetic testing, like they did a 23andMe, for example, 6 years ago, does that get utilized at all, or is it you have to go through the new whatever the test is called or do whatever the mechanism or method is?
That's my favorite question. Um, I'll reverse the question for you. Why would you need a full body MRI or CT if you have done an X-ray of your hand?
Okay, so the ancestry is very limited, that it's not getting down to the
Everything limited. They have done a SNP. What SNP-based technology is? An older technology, cheaper technology. If you have an encyclopedia of everything, all the information there, and you're trying to pick the chapter randomly, and you have maybe made a method that is going to pick the same chapter multiple times, but sometimes you may miss it by closed eyes. You may be successful in many times, many times you'll miss it. But picking up a chapter or page does give you information about the whole book. No, it does not. So SNP-based testing was a cheaper way because we did not have a power to analyze the whole genome in a timely manner. Cost was very high because now the cost of the whole genome is much cheaper than the SNP-based testing. So all these ancestries.com, by the way, it was sold to BlackRock last week. So at a $4.5 billion. So you made them money. Your data, they had a data of 20 million people who sent up their sample SNP based. Each data was valued at $200 a sample. So roughly, so your data was $200 a sample. They made money on.
They charged you 100 for the sample, and then they sold it for double after. That's interesting.
Exactly. So BlackRock is a real estate company, owns a genetic company now. You can think the value of healthcare is changing already. So those testings, 23andMe's and Invitae, nothing against those companies. They helped us move the science forward, but they also destroyed the common understanding. People think I got a genetic test done, I'm negative. It's wrong theory because you got an X-ray done, random X-ray done of some organ. You have no clue of the whole body, of the whole CT, or the MRI you haven't already got done. You're assuming you is negative means zero value because what you do is you're looking for the same gene in breast cancer. Look, is it a BRCA1 and 2 gene? You say negative. Okay, you don't have a breast cancer gene. It's a wrong approach. Many people get a breast cancer despite being negative BRCA1 and 2. Many actresses, there's been on social media talking about that all the time. Why? Because there are other genes out there. Target approach is an old technology, old approach. It used to work when we didn't know the complete analysis. X-ray had a role to play, but MRI gives us more information.
So you guys are doing whole genome sequencing, and then you're future-proofed for whatever new literature connects one sequence to a condition then.
One test. Every human needs a one whole genome test. But if you do SNP-based testing, you do SNP-based testing every day in your life, depending on the question you have.
How long until this is standard of practice, just part of, when you get born, you get your genome sequenced, and then for the rest of your life certain precision changes or things to avoid?
Well, we have some babies who are born on the day the samples were taken in Calgary, and some parents are now making all their decisions based on the genome. UK, they have done 100,000 genome project for babies, especially looking for rare syndromes and diseases. Because a lot of people and lots of parents are worried, and the kids have the problem, but don't know what the problems are. Is autism is a real diagnosis of autism? There's a debate about itself in the medical communities, if it's a real diagnosis. We know that ADHD is more often seen in kids that are eating more processed foods. Just yesterday, Nature article published. So we know that the evidence is there, and ADHD incidence went up significantly last few years since COVID also, as more processed foods we are eating too, same time. So is it a real diagnosis? Is it funded by the pharma company diagnosis? The way depression was, or why certain communities are getting these things, why not other communities are getting these things. So I do believe how to become a mainstream. I think it's going to become mainstream very, very soon. As the cost of whole genome sequencing has come down, it barely costs about $100 USD. Obviously, the investment for the lab, etc., and the analysis is expensive. So, as our company, like a Genomics software we have built, and the mobile applications will getting deployed soon, people who have the whole genome done. So imagine, fast forward a year, our company launching a new technology called PG Arrow, and the technology is already built. We're launching next year. So your whole genome file is uploaded, and now you'll never have to worry about it. In your mobile application, you have everything now. All the drugs you may interact, drug-to-drug interaction based on DNA, and how you're going to be the side effect, everything there. So when you go to a doctor, you just say, Dr. Kapoor, hold on, let me check in my phone if the statin you're prescribing is the right statin for me.
Very cool.
Technology is here. It's just you don't have it. It'll be there.
Coming soon. Amazing. Well, I can't wait. And just being mindful of time. I know you got to hop off right away. But just before we got started, you mentioned you are putting on the Precision Health Calgary conference coming up on November 16th. I just want to make sure we get a chance to shout that out for anybody who might be interested in learning more. Give us the spiel. What's going to be all on the agenda?
Well, agenda is for precision health and longevity medicine. It's a one of a kind medicine, trying to bring science to the mainstream. There's a people talking about longevity medicine on the outskirts. I want to bring it to the mainstream side and give a scientific basis of everything we're doing. You want to do mTOR inhibition or IL-11 inhibition or whatever the strategy you want to deploy for the future today. You want to do it safely as a practice medicine, so you can come and learn. So there'll be multiple fasts of this day. So Friday evening will be a welcome reception, and the five different segments will be divided from AI to biohacking to oncology, cardiology, nutrition, mental health, geriatric medicine, and many different parts of medicine will be covered. Significant scientific data inside the whole day for Saturday, and in the evening we'll have a reception dinner with a keynote speaker. So it's a one of a kind conference, and we are hoping to become a multi-day, but it's the first one we're starting, Precision Health and Longevity Summit. We want people to come. We don't call it a conference, we call it a summit, because we want everyone participating in that and sharing their ideas, wisdom, and we learn from each other. We'll have a panel discussions, we'll have some presentation that some scientific discoveries will be shared at that time. We'll be getting speakers from globally traveling all the way to Calgary. I would love everyone to come and participate.
Incredible. Well, thank you so much for spearheading this initiative and many others. I'm sure there are many people out there who appreciate you taking the time to advance the field of healthcare in a direction that makes sense for the individual.
Thank you so much for having me.